We will be proceeding with the INASL oral session. I request the chairpersons and the judges for this session, Dr. Vivek Saraswat, Dr. C.E. Eapen, and Dr. Anil Arora, to please chair and judge this session. The time allotted is 8 minutes plus 2 minutes discussion. The first speaker for this session is Dr. Arun Sanyal.
Good afternoon. I think let's start with this INASL session. And for a change, instead of giving us lectures on the topic, we have Dr. Arun Sanyal doing an original presentation of efruxifermin improves fibrosis due to MASH in participants with F2, F3 fibrosis or compensated cirrhosis due to MASH. Results of a 96-week randomized double-blind placebo-controlled phase 2b trials. Arun?
Thank you. Thank you, Vivek. It's a great pleasure for me to present on behalf of all of the investigators of these two trials. So my job today is to just summarize the current status of these two phase 2b trials and where we are with the phase 3. So efruxifermin is a long-acting bivalent FGF21 fusion protein designed to mimic the biology of native FGF21. Now, the key structural attributes due to this linker and making it bivalent is its increased half-life to about 3 days that allows once a week dosing. It also has balanced agonism for FGF receptor 1C, 2C, and 3C, but it does not bind FGF receptor 4, which is really the target for FGF19, a different molecule. The bivalent structure enhances the binding to the target cells, and there is a sustained biomarker response over 96 weeks. So the rationale for its use in MASH and fibrosis is that it reduces liver fat and lipotoxicity. It has direct antifibrotic effects and increases insulin sensitivity. So the first trial is one in pre-cirrhotic NASH with F2, F3. The primary paper has been published in Lancet Gastroenterology and Hepatology. This had 126 patients with F2, F3 fibrosis, and the primary endpoint was a one-stage improvement in fibrosis without MASH worsening. And it had about 2/3 of the patients were F3. It was predominantly the mid-50s, 62% female, 70% type 2 diabetes, and importantly, 16% of patients were previously experienced with GLP-1 receptors. 3-arm study, placebo, and low-dose efruxifermin, high-dose efruxifermin, which is 50 milligrams. And as you can see on the right, at the end of 96 weeks, 75% of patients, there's a nice stepwise, so there's a dose response, number one. Number two, at highest dose, 75%, that is 3 out of 4 patients, achieved fibrosis response. Now, with the Symmetry trial, which is the in compensated cirrhosis, there are 181 randomized studies and 134 were dosed to week 96. And again, one-stage improvement in fibrosis, very similar in terms of the overall description of the population with respect to age, gender, diabetes, GLP experience, etc. Same dosing, same approach, week 36 and week 96 biopsy. And the final results at week 96 have recently been published in New England Journal. And what you see over here is, once again, a dose response in the completers. So what I'm showing you are the data per protocol, not an ITT, but per protocol. The ITT population's data is shown at the bottom is 12% for placebo, 29%. But then there were people who were considered non-responders because you didn't have end-of-study biopsy. But if you looked at those who had both, it was about a 40%, 39% responder in terms of reducing fibrosis. So now we're talking about reversing cirrhosis because all of these people had cirrhosis coming in. When you look at the NITs, I'll show you a cluster of data where for each one on the left will be the F2, F3 in the blues, and in the purples you will see the data for F4, okay? So what you're seeing here is from placebo, stepwise, again, improvement in liver stiffness with a absolute change of about 6 to 8, about 7.2 at the highest dose in the pre-cirrhotic and 7.1 in the cirrhotic population. Similarly, if you look at the ELF score, where 0.5 is the line you want to cross, in the pre-cirrhotic, it's minus 0.8. In the cirrhotic, it was right at about minus 0.5. Now, if you look at the ELF score and you look at the distribution of those who worsened, remained the same, or progressed, and this is shown in terms of 0.5, more than 0.5 to 1, then more than 1, right? So greens indicate at the top that they are improving. The reds at the bottom indicate they are getting worse. So you see that at the top, in the F2, F3, the proportion of people who are improving progressively more in the green, and in the cirrhotic population, you actually see both a symmetrical improvement in the increasing number. The size of that green bar keeps increasing as you go to the right, and the size of the red bar essentially decreases. So you're seeing a symmetrical, which again gives us a lot of confidence that these are real findings and not really just a fluke. If you similarly look at the liver enzymes, all of these show that the liver enzymes continue to improve despite not starting at very high levels to start with in these populations. In terms of triglycerides, both studies show F2, F3 and cirrhosis showed improvement. In terms of HDL cholesterol, it shows significant improvement. Very interesting, in the pre-cirrhotic, the LDL cholesterol change was flat, but in the cirrhotic population, both the placebo and the treated patients tended to get better. But the main effects are on triglyceride and HDL cholesterol. If you look at insulin resistance, the HOMA-IR gets better, but you see actually the C-peptide is getting better. So that means that the pancreatic beta cells are not having to work so hard. So you're really resting your beta cells, which is very, very encouraging data from a metabolic standpoint. When it comes to safety and tolerability, again, most AEs are gastrointestinal, mild and transient. The SAE patterns are similar, no reported DILI, and there's a small but significant reduction in bone mineral density, but there were no increase in fractures up till now, and this is an adverse event of special interest. So to summarize, across both F2, F3 and compensated cirrhosis, efruxifermin improved fibrosis by histology and NITs. Early fibrosis response was sustained through week 96 and improved disease drivers such as MASH, lipids, insulin sensitivity, and the AE profile is quite acceptable. And phase 3 programs are currently enrolling. There are multiple sites in India. So please, if you are one of these sites, please do enroll in this, because this is going to be a very important molecule in the armamentarium against NASH. Thank you.
Thank you, Dr. Sanyal. I think we can have some questions from the floor.
Dr. Shiva Prasad, there was a recent network meta-analysis which analyzed all treatments for MASH that was published in Hepatology, and both the ferments, Pegoza and Efruxy, were right at the top in terms of both efficacy in all across. Do you think really this is the best current treatment that is going to matter the most at the moment among the available drugs? Do you agree with the findings of that network meta-analysis?
I think the FGF21s are definitely going to be very powerful players. Their long-term benefit on the cardiovascular, renal, all the comorbidities is not yet established. So I think there's still work to be done. But purely if you just from a liver-centric point of view, they're going to be a leading class of molecules in my view.
Yes, Ashish?
Yeah, excellent study. So in both the trials, you had 60 to 70% of diabetics. So what anti-diabetic medications were they on? Were they GLP-1, SGLT2, because all those will also impact fibrosis?
Yeah. So
and did you do a subgroup analysis of non-diabetic?
Yeah. So time did not permit all of that. So yes, benefits in both diabetic and non-diabetics. Most of the diabetic patients did not get GLP. I showed about 15 to 20% were on GLP, on stable GLP, and met the criteria for inclusion. And as I showed in my previous talk, in that population, there was a further reduction in liver fat and liver enzymes in those when by addition of efruxifermin, whereas those in the placebo did not really change further. So there may be potential value to combining. There are actually now molecules that have been developed, that one single molecule hits both GLP and FGF21. So those will be coming into play soon. So this is a very exciting time.
And subgroup analysis on
And subgroups. So I think with the non-diabetic and diabetics have been looked at, and it doesn't seem to make much of a difference. It works equally well.
Thank you.
Yes, Mike too.
Hello.
Quick question, please.
May I continue?
Quick.
Yeah.
Because you're out of time now.
That's a very good study on efruxifermin, but you mentioned that towards the end, the synchrony trial is progressing, and especially the synchrony histology. I just wanted to know your view on the recently released the AIM-NASH tool and its qualification by the European Medicines Agency. How important it is going to be for all the trial centers to include that as a tool?
Oh, the Path AI
Yes,
digital
right.
pathology.
Path AI
tool.
AIM-NASH tool.
Yeah, I think it's approved in Europe. It's not approved everywhere, so there is no requirement to do it. And I think those people doing phase 3 trials will have to decide whether they want to use digital pathology in addition to conventional reading manually by the pathologist in order to include patients and also to evaluate response. So I can tell you that the AIM-NASH is not yet approved in the US. So certainly from a US perspective, there is still a requirement to get a full, proper classical reading. It may change down the road. And I know that Path AI is working very hard to have AIM-NASH approved as a standalone tool, without having. Right now, it's as an aid to a pathologist as opposed to standalone, but I think that may change down the road. When it does, then I think that'll be another way that people can enroll into trials.
Well,
although where the world is going is towards a non-invasive approach to identifying the study population as well as treatment response. That's sort of where the field is going.
Thank you. Thanks for that. I think we can move on to the next presentation.
Thank you. May I invite the next presenter, Dr. Sandeep Singh Sidhu, who will present on bovine colostrum to treat severe alcohol-associated hepatitis and RCT.
Thank you, chairpersons and my dear colleagues. I'll move on to the presentation. We have multiple principal investigators from various places like PTI, AIMS, and SMS Hospital Jaipur and CMC Vellore. This trial is registered with the clinical trials site. Corticosteroids, although widely used, however, have only a short-term approval of 20 days survival. Larcostrol, that has been recently been approved, the short-term approval, is a DNA methyltransferase inhibitor, was associated with a non-significant improvement in 90-day mortality at both 30 milligrams and 90 milligrams versus placebo. Thus, according to FDA, there is a clear unmet need for a safe, effective, and durable therapies for patients with such severe alcoholic hepatitis. The methodology includes eligibility criteria as per Crab et al. With onset of jaundice within the prior 8 weeks and consumption of alcohol of more than 60 grams in males, AST being more than 50 and the ratio of AST-ALT being more than 1.5, a MADRS discriminant function being more than 32, a MELD score being more than 20. This was a phase 3 multicenter parallel group double-blind randomized placebo-controlled trial. The randomization was performed centrally using the Trans-ERP network for clinical trials services from Netherlands. The participants were administered either 20 grams of freeze-dried colostrum or placebo 20 grams 3 times a day for 4 weeks. The allocation was masked from patients, investigators, and statisticians. In the trial profile, we screened 613 patients, out of which 174 patients were randomized, 89 were allocated to colostrum, and 85 were allocated to placebo. In the bovine arm, 14 discontinued intervention and 2 were lost to follow for primary outcome. In the placebo arm, 41 discontinued intervention and 12 were lost to follow for the primary outcome. The ITT analysis was carried out in 89 patients in the bovine arm and 85 patients in the placebo arm. The primary outcome was an all-cause survival at 90 days. The secondary outcome was an all-cause survival at 30 days, change in the MELD score and the DF score from baseline to 30 days, change in the serum endotoxin and the tumor necrosis factor levels from baseline to day 30, change in interleukin levels 6 and 8 from baseline to day 30, and incidence of sepsis episode from baseline to 30 days. The sample size calculation was based on a study from India by Singh et al., in which the 90-day survival was 78% in the DSSF arm, which was significantly greater than 22% in the standard medical treatment arm. We used a controlled event rate of 22% and aimed to detect a moderate 20% absolute improvement in survival, which would be clinically meaningful. The primary outcome analysis was conducted using an intention to treat population. Survival at 90 days was compared between the two arms using a Kaplan-Meier survival estimates, with differences assessed with the long-range test. A Cox proportional hazards regression model was used to estimate the hazard ratio. The proportional hazard assumption was evaluated using the Schoenfeld scaled residual plots to address a violation of the hazard assumption. The restricted mean survival time for both the treatment groups was analyzed over 90 days. The baseline profile, the chief features are all our patients were males, majority had cirrhosis, a good number of 66 to 72% had ascites, and most importantly, the median MELD score was 30.2 in the bovine arm and 31.5 in the placebo arm. The median DF score was 69 in the bovine arm and 83 in the placebo arm. The primary outcome showed an improvement in survival at 90 days of 89% in the colostrum arm compared to 57% in the placebo arm. This Kaplan-Meier curve shows especially that the number of events, the number of mortalities that took place mostly took place in the first 30 days, and thereafter there was hardly any mortality, especially in the bovine arm. The global Schoenfeld test showed that there was a violation of the proportional hazard assumption. The secondary outcomes showed that the survival at 30 days was significantly higher in the colostrum arm. There was a marked decrease in endotoxin and TNF alpha serum levels from baseline to 1 month. And colostrum also induced a significant decrease in sepsis episodes over time compared to placebo. We did a sensitivity analysis to show the robustness of the primary outcome analysis. This showed that relative risk of mortality was significantly lower in the bovine arm compared to the placebo arm in both the best case scenario and the worst case scenario. A forest plot of the subgroup analysis also showed that irrespective of the subgroups of age, alcohol consumption, alcohol relapse, or MELD scores, the treatment arm fared much better than the placebo group. Thus, colostrum significantly reduced the episodes of sepsis over the 4-week treatment period compared to placebo, and significantly decreased the serum endotoxin and TNF levels at 1 month. When we compare the DF scores and the MELD scores of the Indian studies versus the Western studies, it is clear to us that the Indian studies had a much higher DF scores and the MELD scores, thereby underscoring that the disease that is seen in South Asia and India is much more severe than the Western studies. And the Kaplan-Meier survival curve in our study compared to the STOPPER trial showed that while most of the deaths had occurred in the first 30 days, in the Western studies, there was a gradual leveling of the events over a period of 1 year. The key strengths of this study was in the inclusion of real-world patients with very severe alcoholic hepatitis, complicated by sepsis, acute kidney injury, and upper GI bleeding, subgroups often excluded from the corticosteroid trials. The survival benefit observed with colostrum likely stems from the restoration of gut barrier integrity, reduced systemic endotoxemia, and decreased hepatic inflammation. These effects suggest that targeting the gut-liver axis might be a novel therapeutic approach. Thus, bovine colostrum significantly improved 90-day survival in patients with very severe alcoholic hepatitis. It's a safe, inexpensive, and orally administered biological agent, giving a promising treatment option, particularly in resource-limited settings where liver transplantation is often not feasible or possible. Our findings merit validation in larger multinational trials. Just to the last cartoon, I would like to show you how bovine colostrum works. There are 3 components of bovine colostrum. One is lactoferrin, IgG, and third is short and fatty acids. The lactoferrin is converted to lactoferrin B, which is bactericidal. Both the lactoferrin and the IgG, they neutralize the endotoxins. The IgG improves the leaky gut mucosa and converts it in a healthy mucosal barrier. Thus, the PAMPs that are traveling through the portal vein are decreased in quantity, and the Kupffer cells are not activated. Thereby, there's a reduced production of cytokines such as reactive oxygen species, interleukins, and alpha TNF, and this decreases the neutrophil recruitment, thereby mitigating hepatic inflammation and hepatic necrosis. Thank you.
Thank you. That's very impressive results. May I ask for comments, please? Rakesh.
Dr. Sidhu, very interesting data. I think each group had about 80 to 90 subjects.
89, 85.
In the one group, there were 41 dropouts, in the other, there were 14. Why was there such a large difference in dropouts between the two groups? And the second question I have is, if you look at the survival curves, till 15 days, there is virtually very little deaths in both the groups. And then suddenly in the control group, over the next 6-7 days, all the deaths happen, and then again the curves become flat. How do we explain this? What happens during those 6 or 7 days that everybody suddenly drops off at that time?
See, these patients at baseline had a very severe disease. The baseline septic events were approximately 50 in the bovine arm and 75 septic events in the placebo arm. And this accounted for sudden deaths in the first
But there were very few deaths in the first 15 days. All the deaths are between day 15 to day 21.
Yeah, because these patients were very sick and they survived for a period of 2 weeks. The reason for that survival, I should point out to you, is that if you see the survival in the placebo group is also close to around 57%. This is due to improvement in the standard of care of treatment and improved ICU practices. So that explains why these patients survived for some time, but ultimately because of the severity of disease, they died.
With so much difference in dropout rate between the two groups, do you think the results still are robust?
The results, that's exactly the reason why the amount of dropouts were accounted mainly by simple fact is this is the high mortality rate in the placebo group. That accounted for the major amount of dropout, and the secondary issues were 2-3 patients dropping out. One had lactose intolerance.
If they died, then they won't be dropouts, right?
I think there are more questions from the other mic. I think we please move on to the last question.
Yeah, thank you, Chalastani from Indianapolis. Great results, though remarkable. Can you tell more about the colostrum that you are administering? That's 50 grams, and where'd you get that dose?
This initially, actually, we borrowed this dose from a study by Bolke et al. Way back in 90s from Germany, and we acquired this from a firm in Gujarat. There is a firm that produces commercially bovine colostrum. This bovine colostrum was subjected to analysis by 2 different independent firms from Mohali and from Delhi, and they both showed that the IgG content was close to around 34%, and they also gave the identical total protein as well as the levels of carbohydrates and fats.
You know, we have done with Arun, we have done a trial with Australian bovine serum that's called Imuran 124E. It was a remarkably negative study. There was really nothing, not even TNF alpha. So I was just very striking that, but the doses were very different. I just wondered if the dose was the issue here.
One of the main reasons is the dose. If you look at the study done by Bolke et al., he initially used a dosage of 60 grams in his patients preoperatively to patients who underwent major abdominal surgeries, including pancreatic surgeries. And he repeated the same study in patients who underwent major cardiovascular surgeries with a lower dose of 40 grams. And he found that the endotoxin utilization capacity and the serum endotoxin levels were considerably lower in patients who had a higher dose as compared to the lower dose patients. So dose probably plays a very important role. And one must understand it is a composite of not one but multiple biological substances like IgG, short-chain fatty acids, and lactoferrin, and they all combine to give a harmony, and they improve the microbiota in the gut, and they also improve the leaky gut barrier. And therefore, what your study was aiming at was improving the IgG content alone. It was a hyperimmune IgG levels. So they were focusing only on one particular constituent.
I think I'll have to interrupt, Sidhu. Thank you very much for an excellent presentation. We are well over time. You could please continue the discussion off the mic. We move on to the next presentation in this session. I'll invite Dr. Parminder Kaur to present the paper on growth hormone therapy prevents complications and ACLF in decompensated cirrhosis. a multimodal strategy targeting regeneration, immunity, and nutrition. Dr. Kaur.
Good afternoon, everyone. I'll be presenting our recent work entitled Growth Hormone Therapy Prevent Complications and ACLF in Decompensated Cirrhosis, a multimodal strategy targeting regeneration, immunity, and nutrition. This work was done under the guidance of Dr. Nipun Verma and Dr. Virender Singh in Department of Hepatology, PGI Chandigarh. We have nothing to disclose. Decompensation lead to marked reduction in the survival, and apart from the major complications like malnutrition, sarcopenia, immune dysfunction adds to the mortality. GH resistance is associated with low IGF-1 levels, low circulating IGF-1 levels, and this resistance parallels the disease severity, and low IGF-1 levels are associated with complications, sarcopenia, frailty, and mortality. So the aim of present study was to evaluate the effect of growth hormone therapy on multimodal axis, including complications, survival, nutrition, immunity, and regeneration in cirrhosis. So this was a prospective single-center open-label RCT conducted at PGI from December 2020 to 2024. In this, we included the patients with decompensated cirrhosis, any etiology, and excluded those with AD-ACLF at enrollment, active alcohol use, and on antiviral therapy initiated in the last 6 months. Sample size was 92 patient, 46 in the each group. Primary endpoint of the study was complication-free survival, which was inspired from the Liver Hope Consortium and included ascites, HE, GI bleed, bacterial infections, and AKI. Secondary outcomes included overall survival, hospitalization, disease severity, muscle mass and function, nitrogen balance, frailty, and other outcomes. The primary analysis of the study was intention to treat analysis, which included all the patients enrolled, and we also performed protocol analysis in which the patient who completed 12-month follow-up and with no major protocol deviations were included, and we also did a separate analysis based on the IGF-1 response. And within group changes were compared, and longitudinal changes between the groups were compared using percent delta changes. Repeated measures were used, analyzed through mixed model effect, and time to event analysis was performed. So coming to the results, as we can see in the consort, out of the total 401 patients screened, we enrolled 92 patients, 46 in the control arm in which the patient received standard medical treatment, and 46 in the growth hormone arm in which the patient received growth hormone therapy plus standard medical treatment. Growth hormone was given subcutaneously daily at a starting dose of 2 international units per day, and dose was titrated based on the IGF-1 levels at 1.5 month follow-up. Patients were followed up for a duration of 1 year, and in the ITT analysis, we included all the patients, and in per protocol analysis, in the control arm, 43 patients were included, and in the growth hormone arm, 31 patients were included. These are the baseline characteristics of the patients enrolled, and these were comparable between both the arms. Median age of the patients were 45 to 50 years. Majority of them were male, and most common etiology was the alcohol related. And majority of the patients belong to CTP B class and with a median MEL score of 14 to 15. So the primary endpoint, complication-free survival, was significantly better in GH arm in both ITT and per protocol population, whereas overall survival showed a trend in ITT population and which became significant in the per protocol population. When we looked at the individual complication, incidence of ascites and incidence of ACLF was significantly better in the GH arm. Incidence of hospitalization was significantly better in the GH arm. MEL score decreased significantly in the GH arm. GH level decreased and the IGF-1 levels increased in the GH arm. Skeletal muscle index improved in the GH arm compared to the control group with fewer number of patients with the sarcopenia at follow-up. Liver frailty index decreased with the GH treatment. Myostatin, which is a negative regulator of muscle growth, decreased in the GH arm. Nitrogen balance improved in the GH arm, which was mainly derived by the decrease in the nitrogen output. Apart from increasing fat-free mass, GH treatment led to increase in the intracellular water, whereas in the other arm, extracellular water increased. Liver volume showed a trend toward the improvement in the GH arm. Circulating hepatocyte growth factor, augmenter of liver regeneration levels increased, whereas the circulating levels of cell death markers, apoptosis and total cell death decreased in the GH arm. Resting neutrophil reactive production of reactive oxygen species decreased in the GH arm, and neutrophil phagocytosis increased in the GH arm. So when we stratified based on the IGF-1 response and compared with the control group, we found that IGF-1 responders had a significantly better complication-free survival and overall survival compared to the control group, which was not observed in the IGF-1 non-responders. And we did causal tree analysis to find the best subset of patients which derived the maximum benefits, and it showed the patients with MELD less than 16 and IGF-1 levels between 34 to 54 and albumin more than 3.7 at baseline had the maximum benefit from the treatment. And we also adjusted for the effect of diet and exercise, and we found that the effect of GH were independent of diet and exercise. And the median adherence to the growth hormone was 96.2% of the prescribed dose. There was no major serious adverse event. Minor adverse events were observed, like injection site reaction, joint pain. Strength of the study are a randomized control trial design of the study with rigorous follow-up and detailed complication capture and adjustment for the confounders. However, open label design of the study may introduce the inherent bias, and the predominantly male and alcohol-related etiology limit the generalizability of the study, and we could not explore the mechanistic pathways. So to conclude, GH treatment in cirrhosis lead to the better synthetic and regenerative capacity, reduced nitrogen output and anabolic action, improve the muscle mass and frailty, which leads to the less complications, and reduced oxidative stress along with the improved frailty and improved muscle mass translates into the reduction in the ACLF incidence. So patient selection is the key. Adherence to the GH therapy is crucial, and monitoring IGF-1 levels can help the treatment and maximize the benefits. Thank you.
Thank you, Dr. Kaur. I think overshot the time a bit. So can we have one quick question from the floor?
Is there any increased risk of HCC with long-term GH therapy? Just wanted to know.
Sir, in this study, it was not observed. And in the literature, IGF-1 increasing IGF-2 levels are associated with the increase of HCC. So we did not observe HCC risk.
Just before this, we had one study thesis on this GH, and then we followed patients with the help of the CT, and there was no increase of the HCC.
Okay, thank you very much, Dr. Kaur. Let's move to the next presentation.
May I invite the next presenter, Gokula Priya Ramachandran, to present the work on effect of probiotics on gut permeability and inflammation in cirrhotic patients awaiting liver transplantation, RCT.
Thank you, judges. Good afternoon, all. This is a part of my PhD study. Chronic liver disease nearly account for 2 million deaths around the globe and 0.5 million deaths in India, which is mainly due to cirrhosis, hepatocellular carcinoma, and viral hepatitis. For patients with end-stage liver disease, liver transplantation is an acceptable option since it prolongs survival and improves the quality of life. But during the waiting period for liver transplantation, cirrhotic patients are more prone to complications, which increases the risk of gut dysbiosis and inflammation, which further increases the episodes of hospitalization, leads to poor prognosis, and increases morbidity and mortality. So, along with the standard treatment, we believed gut-targeted supplements may be helpful in decreasing these complications, and so we chose probiotics. As per World Health Organization, probiotics are live microorganisms which, when administered in adequate amount, confer a health benefit to the host. Based on these beneficial properties, we aim to study the effect of probiotics on the gut permeability markers and inflammatory markers in cirrhotic patients waiting for liver transplantation compared to placebo. Methodology of the study: this is a randomized double-blind placebo-controlled trial conducted on liver cirrhotic patients referred for liver transplantation, Jipmer, Puducherry. Total sample size is 215 patients, 108 in the probiotic group and 107 in the placebo group. The intervention used is probiotic VSL3, which is a multi-species and a combination of 8 strains of bacteria, while placebo arm received a similar looking capsule filled with cornstarch. The duration of the intervention is 6 weeks, that is 2 capsules per day prior to breakfast and dinner. Inclusion criteria are both male and female aged above 18 years with liver cirrhosis and those who are on active status in the waiting list and able to provide informed consent. Patients with HIV infection or with chronic GI disease or with polycystic liver disease were excluded from the study. And also patients were under alcohol intake or under lactose or probiotics or antibiotics therapy in the past 4 weeks were also excluded from the study. Patients whose liver transplantation is scheduled within 6 weeks from the day of enrollment was not included into the study. This is the consent flow diagram. Based on these criteria, we enrolled 215 patients and they were randomized by 1:1 allocation ratio into intervention and placebo arm. So at baseline, clinical history and blood samples were collected and urine samples were collected in a very less patients, that is number 10 is equals to 40. Telephone contacts were maintained with these patients in order to maintain compliance and also to decrease dropout. After 6 weeks, 93 patients in the probiotic arm and 90 patients in the placebo arm completed the trial. And again, their urine samples, blood samples, and clinical history was collected, and their data were analyzed by intention to treat analysis. Table 1 shows the baseline demographic and clinical characteristics. Among 215 patients, the mean age was 48 years, and majority, that is 92%, were male. And the main causative factors for liver cirrhosis was chronic alcoholism, which was noticed in 72% of the patients. 50% of the patients were in CTP-B and 28% of the patients were in CTP-C, and about 65% of the patients were above milk sodium above 15. In this table, you can see the effect of probiotics and placebo on biochemical and liver function parameters of cirrhotic patients waiting for liver transplantation. At baseline, all the parameters were similar across both the group. Either a probiotic VSL3 or placebo was not associated to alter any of these markers. However, probiotic intake significantly decreased the plasma ammonia levels when compared to baseline. Post-treatment comparison also showed a significant decrease in the plasma ammonia levels. This figure shows the effect of probiotic and placebo on intestinal permeability markers in cirrhotic patients waiting for liver transplantation. Probiotic intake significantly decreased intestinal fatty acid binding protein, tight junction protein occludin, and zonula occludin 1 when compared to baseline. Post-treatment analysis also shows a significant decrease in occludin and zonula occludin in the probiotic group. Probiotic did not alter zonulin and serum lactate. Placebo did not alter any of these intestinal permeability markers. Intestinal permeability was also assessed using urinary lactose mannitol ratio. Though probiotic intake significantly decreased lactose recovery when compared to baseline, no significant changes was noticed in the LMR in both probiotic and placebo group. Subgroup analysis in association with liver disease severity shows that probiotic was associated to decrease zonula occludin 1, occludin, and D-lactate, mainly in patients with CTP-B. No similar changes was observed in the placebo group. Inflammatory markers HSCRP and serum intraleukin 1 beta significantly decreased when compared to baseline in the probiotic group. Post-treatment analysis also shows a significant decrease in HSCRP and IL-1 beta in the probiotic group. Placebo group did not show any changes in these inflammatory markers. Subgroup analysis in association with liver disease severity shows that HSCRP and TNF-alpha significantly decreased in decompensated patients following probiotic intake, and IL-1 beta was significantly decreased in patients with incompensated liver disease. Similar changes was not noticed in the placebo group. Probiotic supplementation significantly reduced CTP scores when compared to baseline. No changes were seen in the probiotic group. MELS sodium was not significantly changed in any of these groups. To summarize, probiotic supplementation was associated with decrease in intestinal permeability markers and inflammatory markers, and also helped in reducing disease severity. During the study period, probiotics was very much safe and well tolerated, and no serious adverse events were noted. And so it can be considered as an adjunct along with the standard treatment. Multicentral trials may be helpful in confirming these benefits and also to assess the long-term benefits. So to conclude, probiotic supplementation for 6 weeks to cirrhotic patients improved gut barrier function and also reduced systemic inflammation in cirrhotic patients awaiting for liver transplantation. I thank DST and JIPMA for financially assistance for this study. Thank you for your kind attention.
Thank you. May I invite any comments?
Yeah, I'm Dr. Shiva Prasad. I was a little curious to see that you had more than 200 patients enrolled and the exclusions were only 14, whereas two of your main criteria for exclusions was anybody who received lactulose or receiving antibiotic, which includes rifaximin. So how did you get a population of cirrhotics who are not taking lactulose, not taking rifaximin, not taking any other antibiotics, and so that only 14 patients needed to be excluded from your referral pool, and all these patients were referred for transplant, so they are little sick patients. So that is one question. And the second follow-up is, during this time of treatment, if they needed antibiotics or lactulose or rifaximin, then what was your policy? They were given irrespective of the therapy, or were they kept off these therapies because it might interfere with your results?
So once after screening these patients, only these patients were not given lactulose and antibiotic. If they had any serious complication, the standard treatment was given to them.
Okay, so brief question, excellent presentation, and congratulations on the study.
Thank you, sir.
As you have shown, there is an improvement in systemic inflammation. Were you able to attribute the follow-up complications such as acute and chronic liver failure in these patients, as systemic inflammation is clearly shown to be associated with occurrence of ACLF?
Sorry, sir, can you please repeat?
What was the occurrence or incidence of acute and chronic liver failure on follow-up? Did you attribute the follow-up of these patients? Could you see that some of these patients were progressing to acute and chronic liver failure? Incidence of acute and chronic liver failure between the two groups?
Loss to follow-up was mainly due to mortality, as well as they were not they were hospitalized at a different hospital. They didn't come back. So we don't have any records regarding their outcome.
You use the VSL3.
Dr. Mishra, I think Dr. Sidhu is standing on the other mic.
Sure.
Following.
A very simple basic question. Where did you take the dose of VSL3 capsules to be twice a day?
So you've asked my question.
Dosage, sir?
What was the base of your giving 2 capsules a day? What was the study that from which you took the dosage to be given 2 capsules a day of VSL3?
It was based on the previous studies, sir.
Most of the previous studies have been given 3 capsules a day.
No, I don't exactly remember the study, but based on the previous study, we chose 2.
Moreover, the probiotics are a highly subjective group of things to be given to patients, because the constituents are really not well classified, and their effects subsequently are also very subjective.
Yes, Dr. Mishra.
So you use VSL of some company.
Yes, sir.
What company was that?
Sun Pharma, sir.
Sun Pharma. Recently, because the biome has changed now.
Has changed.
Sir, yes, sir.
So it's not the same VSL3 that was earlier.
Not the earlier one. This,
So instead of saying VSL, you could have given the chart basically what are the contents of that.
Oh,
Otherwise,
okay.
the things have changed. So if you ever used
Yeah,
it
I have
earlier,
the details,
it was
sir.
a different biome. Now it's a different biome.
Okay.
Whiz biome. Okay, I think thank you very much, Dr. Gokul Priya.
Thank you,
I think
sir.
I'd like to thank all the presenters for very good presentations. A session in which all the presentations were randomized controlled trials of high quality, and they were very well presented, and there was good audience participation. I'd like to thank everyone. Thank you.
Thank you, chairpersons. Can I request the speakers to come on the stage? We'll have a quick picture with the chairpersons. I request all the speakers of this session to please come on the stage if they're in the auditorium. Okay. You can collect.